Hello everyone, I'm Dr. Rashad Al-Attar. We'll talk today about Pheochromocytoma. Pheochromocytoma is rare neuroendocrine tumor of the medulla of the adrenal gland. From 85 to 95% cases originating in the chromaffin cells or extra-adrenal chromaffin tissue that secrete excessive amount of catecholamine, epinephrine and norepinephrine hormone that regulate heart rate and blood pressure. Pheochromocytoma is a rare disorder, equally common in women and men. Disease can occur at any age, rarely occur after the age of 60 years old. So again, to remember, pheochromocytoma is a neoplasm of adrenal medulla, usually unilateral and benign. To remember it well, always know rule of 10. 10% bilateral, 10% malignant, 10% extra-adrenal, 10% multicentric, 10% familial. Common presentation in patients with pheochromocytoma: paroxysmal headache, palpitation, tachycardia, perspiration, hypertension as tumor secrete catecholamines. Clinically suspected in younger patients with hypertension. Again, don't forget that pheochromocytoma 10% tumor, 10% extra-adrenal, 10% in children, 10% familial, 10% bilateral or multiple, 10% recur, 10% malignant, 10% discovered accidentally. Pheochromocytoma, 3 most common symptoms: mnemonic PHE, palpitation, headache, episodic sweating. How to diagnose pheochromocytoma? We will talk now how to diagnose pheochromocytoma in the past, present, and future. Through biochemical diagnosis, tumor localization, pathological diagnosis, genetic predisposition, post-surgical testing and management, and the therapy. In the past, biochemical diagnosis based on urinary phenyl mandelic acid, catecholamine, and total metanephrine and plasma catecholamine. In the present, plasma and urinary fractionated metanephrine and catecholamine. In the future, will be based on plasma marker derived from proteomics and RNA technology. Regarding tumor localization, in the past through X-ray, in the present CT, MRI, MIBG, bone scan. In the future, it will depend on functional and molecular imaging with PET. Pathological diagnosis: in the past, chromaffin reaction. In the present, histopathological marker and the presence of metastasis. In the future, DNA, microarray, and molecular marker. Genetic predisposition, family history. In the present, mutation analysis. In the future, will depend on high throughput sequencing microarray based on genotyping. Post-surgical testing and management. In the past, biochemical testing 2 to 6 weeks post-surgery. In the present, biochemical testing 2 to 6 weeks post-surgical annual screening of all patients. In the future, biochemical testing 2 to 6 weeks post-surgical annual screening of selected patients based on prognostic molecular marker prophylactic therapies in selected patients. The therapy: in the past, adrenergic blocker like alpha-methyl parathyroidine and use of other drugs for symptomatic relief. In the present, surgical debulking, chemotherapy, MIBG radiotherapy, radiofrequency ablation, cryoablation, chemoembolization. In the future, tumor sensitization to MIBG radiotherapy pathway, specific molecular targeting, cancer vaccine, and gene therapy. In a brief treatment: if surgical, it will be surgical removal of the tumor by laparoscopic adrenalectomy. If not surgical, and medical will be the option through drugs like meteorozine, used to diminish catecholamine production and and simplify chronic management. Preoperative alpha blocker will be given about 14 days before operation, and alpha blocker must be given before beta blocker. Thank you.